chairpersons and the Egyptian Society of Laparoscopic Surgery for giving me this chance to present our experience in 10 years for TA technique. Our study reviews our experience with 869 patients in the last 10 years. Half of them were done in a center of excellence for hernia repair in Qatar, in Hamad Medical Corporation. And it is my honor to participate in establishing this center. The remaining patients were done in Egypt. In the beginning, we used the Ultra Pro mesh 10 by 15. But now we use polypropylene mesh, wide bore mesh or light mesh, with stable or sutured peritoneal closure. In our study, no complications were reported as regard bladder or bowel injury or major bleeding. The median operative time is 55 minutes for unilateral.
Slide special. Slide fix it.
هو مش عامل سلايد.
The median operative time is 55 minutes for unilateral and 90 minutes for bilateral. Median return to normal activity is 5 days. Recurrence rate is 0.9%. 9 patients recurred out of 869. 5 of them were in the first year, in the beginning of the learning curve of the TAPP. The incidence of hematoma and seroma is 0.5%. 60% of patients require mild post-operative analgesia according to VAS scheme. Our study showed statistical significance values as regard the surgical procedure time, the duration of the hospital stay, and mild post-operative analgesia. And it shows no statistical variance as regard the recurrence and the incidence of seroma and hematoma. Laparoscopic TAPP is technically demanding, but in the hands of a well-expert and trained surgeon is safe with high degree of patient satisfaction over other methods of tension-free mesh hernia repair. And now we're going to see some videos to show the tips and tricks of the operation and rare types of hernia. This is the first case. We can see here the defect is present inframedial to the medial umbilical ligament. Usually, we see the inferior epigastric artery, and if the defect is medial, it is direct. If it is lateral, it is indirect. But in this case, the defect is present medial to the medial umbilical ligament, or actually inframedial. So it is a rare type of obturating hernia. The second hernia is called Lucher's hernia. It's a very rare hernia. The defect is present in this case in the lacunar ligament. As you see in the video, we dissect above the superior pubic ramus, where the defect is present here. You can see the superior pubic ramus, and we dissect above the superior pubic ramus to reach the lacunar ligament. The third video shows the removal of infected mesh. The patient, he did the operation somewhere, and he came complaining of collection, and the surgeon decided to do CT-guided aspiration. And he left the drain for 3 months. So we decided to remove the mesh. But the message from this video, don't interfere with seroma. Seroma is not a complication, it is a sequelae of the operation. This case shows bilateral indirect hernia. You can see the inferior epigastric artery here and the defect is medial. If you are in the correct plane, no bleeding, as it is an embryologic plane. You can see the cobalt's ligament here, inferior epigastric artery, and we start to dissect the sac. necessary to remove all the sac. You can remove part of the sac. You can see the vase on the right side, and now the sac is completely dissected. This is the anatomy, triangle of Thun with iliac vessels, Cooper's ligament, inferior gastric artery above. This is the final view, and the keystone for success of this operation is generous space and large mesh. And the beginning we speak of the peritoneum, but now we are using sutures to close the peritoneum. Bilateral direct hernia, the defect is medial to the inferior gastric artery, and you have to stop the dissection at the medial umbilical ligament. You can see the fascia transversalis here. It's very important to dissect the fascia transversalis from the sac. Parallelization of the cord, to dissect the lower flap, to be able to put large mesh and to avoid rolling of the mesh. And you have to leave fat at the floor of the operative field. The peritoneum here is made of two layers, superficial glistening layer and deep layer, should be incised together. Very important step should be done in direct hernia, especially huge hernia, is to fix the fascia transversalis in the Cooper's ligament. In this case, we used one large mesh. I don't prefer using one large mesh because you have to dissect through the medial umbilical ligament which support the bone. So it's better to use two types of mesh. Here we put the mesh below the Cooper's ligament by 2 or 3 centimeters, which is very important to avoid recurrence. New technique is called hydrodissection, or recently it's called the tumescent technique, in which we inject saline. You can add analgesia or adrenaline. You can see now how the dissection is very nice, it's very easy to mobilize the lower flap. And you can see the saline flowing in between the tissues. You can apply this technique when the parietal peritoneum is adherent to the underlying tissues. Very important also to see the lower flap of the peritoneum, to be able to mobilize the flap. And our lower limit, well, you see the vase crossing the iliac vessels. Another method for hydrodissection by using this needle. You perforate the parietal peritoneum and inject saline. And please concentrate at the internal ring now. Internal ring, the peritoneum is raised. And this facilitates too much the dissection. The last case, patient was suffering from irreducible hernia. And now the question is irreducibility considered contraindication to laparoscope in the beginning? In the nursery stage of laparoscopic repair of hernia, it was contraindicated. But now you can do irreducible hernia. We tried many times to reduce the contents to the abdomen. It was very difficult. So we decided to widen the internal ring. But when you cut the internal ring, you have to cut it laterally to avoid injury of the inferior epigastric artery. We cut the internal ring laterally by hook. This is indirect hernia. You can see the inferior epigastric lateral to the defect. And now, after cutting of the internal ring, it becomes very easy to reduce the contents. Thank you very much.
Thank you, Professor Ashraf, for your nice illustrative presentation. And could we allow 2 questions from the floor?
Thank you, Dr. Ashraf. Big number of cases, and we should respect this experience.
Please introduce yourself.
I'm Mohammed Sharshar, consultant Alexander University. كنت عايز اسال حضرتك على البايلاترال هيرنيا في الفيميل patients.
Yes.
Do you cut the round ligament or dissect it? Because I did a couple of cases. When we try to dissect from the round ligament, it is not like the horse.
Yes.
It is very adherent to the peritoneum. So should we cut both round ligament in
Yes,
female patients?
you can cut that.
There's no problem?
No problem.
You should try it. I wanted to raise this point.
Yes.
Thank you very much.
Another question. I would like to ask you about post-operative neurological pain. What's the incidence of the neurological pain post-operative with such type of laparoscopic herniaplasty?
Yes, actually, we don't have a case of chronic pain. About 60% of patients require mild post-operative analgesia according to vast scheme. We don't have a case of reported of chronic pain. Basically, we use sutures to close the peritoneum, and we can use even glue to fix the mesh. Therefore, there is no instance of chronic pain reported in our study.
Thank you.
You're welcome.
Now,